zajmujący się chorobami nowotworowymi układu pokarmowego oraz dr Stanimir Hasardziew, przewodniczący Bułgarskiej Narodowej Organizacji Pacjentów, sekretarz generalny Partnerstwa na Rzecz Pacjenta. Otwieram 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 pacjentów, sekretarz generalny Partnerstwa na Rzecz Pacjenta. Otwieram
because it was very important for us to bring the patient voice into the different streams and thoughts in the European policy. Because it was very important for us. I want to thank you that you make cancer the different streams, even those difficult times of the pandemic, where let's say we easily go into things that are mostly challenging at the moment, even those difficult times of the pandemic, and that's why I say grateful for usually things that are mostly challenging for supporting you, even though difficult times of the pandemic, and that's why I'm very grateful. So next slide, please. I just want to very briefly about the support cancer as an epidemic. I think we are totally aware about that's why I'm very grateful. So next slide, please. What I want to very briefly about the cancer around the epidemic. I think we're 20 different cancer types. Not counting next slide. What I want to very briefly it's of course what you think it's of course what you next slide. So talking about inequalities, accessibility, and discrimination, these are common challenges. Preventive measures, and so talking about inequalities, accessibility, and discrimination, these are common challenges. But preventive measures, so talking about inequalities, accessibility, and discrimination, these are common if that's the case, and of course, pro-COVID-19 safeguards, If we talk about specifically about the process here there are distributions in countries that have very flexible abortion. If you talk about 25% rate process here there are distributions and prevention screening is very relevant. If you talk about 25% rate process where there's very often late or early diagnosis very relevant. If you talk about 25% rate process especially there's very often late or early diagnosis lack of information is a concentration in agents and of course there's very often late or early diagnosis lack of information is a conception percent of variation about that some countries like and of course loads of lack of cancer percent of very often lack about that some countries like on rare entities so it takes a significant amount of time to get about that and then of course lack of countries like on rare entities of being so it takes a significant amount of time to get and then there are 5 effective interventions and I'm also part of the cancer mission seminary and of course there are different interventions prevent and there are 5 effective interventions diagnose as early as possible systemize treatment if you need to treat so you can't prevent and there are 5 effective diagnose and make sure as early as possible systemize treatment if you need to treat so you can't prevent of course otherwise understanding and I just listed some of my experience that we engage in and of course we want to strengthen cooperation and I just listed some of my member states that we engage a lot of inequalities here and we can see the pandemic just strengthen cooperation and I just listed some of my address inequalities and the cross-border healthcare directive has been an important step forward especially rare diseases addressing inequalities reference for healthcare knowledge travels but still we see the Western Europe is very also strong on the European reference but what we really want is that research but still we see the Western Europe I've been engaging in one of the 4 countries related to the reference network but there's also Eurocan for the solid tumors I've been engaging in one of the 4 countries the cross-border healthcare directive has helped, but the resourcing is totally inadequate. And it's very important to synergize cancer activities. It's so great. It's a milestone at the moment. How many activities on the European level are undertaken after years of not so much activity? Your special committee, the cancer mission, the Beating Cancer Plan, Horizon Europe, the European Reference Networks, the Cross-Border Healthcare Directive, synergies on health technology assessment, and so on. And then also activities like the EU trio presidencies that Germany has done a lot in the last half year on getting patient engagement in research started and strengthening patient engagement in research. And this needs to be all seamlessly integrated. We need to remove financial and administrative discrimination in the right to be forgotten. I can tell you, I am myself on a blacklist. I've been on a blacklist for years. I cannot get specific insurances, even though I've been off therapy for a long time already. It's a very important topic, but François Mounier will talk about this. I would also hope that the Parliament would again pick up very important work the Parliament has done in the ample committee on cancer at the workplace. I've quoted the report here, which I still often use so many years later. And of course, the pharmaceutical legislation is currently under review and addressing, for example, also drug shortages. But we would also like to see that information to patients directive is being addressed again, because it failed in the last review of the pharmaceutical package, but it bans us as patient representatives from attending medical conferences, from seeing scientific literature, just because we are not prescribers, but we really need to be in touch with science. And the current information to patients directive was invented before Facebook.
Excuse me.
Next slide, please. Yes?
Should I finish, okay?
Okay, 30 seconds. I just wanted to say there's a huge community other than back in 2003 of cancer patient organizations on the European level, and it's really determined to support whatever you do in terms of all the cancers, the rare cancers, pediatric cancers, and hematology. You can find all the different organizations here. And next and last slide, please. I think it's very important. We want to work with you. Next slide, please. We really want to work with you, and patients and patient empowerment have a crucial role, not just as receivers of healthcare, but to work with you on equal eye level. We are extremely knowledgeable, but we're still the most underfunded and unempowered part of healthcare system. And it sometimes feels like the big elephant on the chair and the small mouse, the patient and the patient advocate at the bottom. We really want to work, but at the moment we're not being resourced, not being involved everywhere. And I hope this is going to be change. So please make patient involvement in all EU cancer policies a reality. And I think you have a huge role with the special committee. Thank you so much.
Bardzo dziękuję za wystąpienie. Zapraszam do głosu Willy Palm, Generalnego Organizacji Zdrowia. Przypominam o konieczności dyscypliny czasowej. Zapraszam do głosu. Bardzo dziękuję za...
Thank you very much, Chair. Thank you also for the opportunity to speak at this hearing. Before I start, I would like to say that what I'm going to present relates more to what I did in my former position.
Przepraszam.
Yes,
czy my możemy spowodować to, żeby mówca był widoczny? Bo tłumacze mają z tym problem.
Sorry, can you hear me?
Przepraszam. Czy my możemy spowodować to, żeby mówca był widoczny? Bo tłumacze mają z tym problem. Widzę, że nie mamy takiej możliwości. Dobrze, proszę kontynuować. Próbowaliśmy zrobić tak, żeby mówcę widzieć i jednocześnie widzieć pokaz slajdów, ale chyba jednak to nie będzie technicznie możliwe. Zapraszam do głosu. Widzę, że nie mamy takiej możliwości. Dobrze, proszę kontynuować. Próbowaliśmy zrobić tak, żeby mówcę widzieć i jednocześnie widzieć pokaz slajdów, ale chyba jednak to nie będzie technicznie możliwe. Zapraszam do głosu. One second, please. We have technical problem. Nie wiem, kto do mnie to powiedział w tej chwili. Okej. Dobrze, to... Dobrze, proszę kontynuować wystąpienie. Będziemy próbowali ten problem rozwiązać w ciągu najbliższych minut. Zapraszam. Willy Palm. Dobrze, proszę kontynuować wystąpienie. Będziemy próbowali ten problem rozwiązać w ciągu najbliższych minut. Zapraszam. Willy Palm. Oddaję głos Willy Palm. Proszę kontynuować wystąpienie. Zapraszam do głosu. Czy Willy Palm nas słyszy? Oddaję głos Willy Palm. Proszę kontynuować wystąpienie. Zapraszam do głosu. Mamy problem techniczny. Proszę o cierpliwość. Czy Willy Palm nas słyszy? Mamy problem techniczny, proszę o cierpliwość. Willy Palm, do you hear me? Willy Palm.
Mr. Palm, could you please press the speak button once? Thank you.
Yes, can you hear me?
Yes, I can hear
Yeah,
you.
I hear you.
Okay, sorry for this. For this, so I will continue to say, and perhaps going to the next slide, in this book that you can see on the slide, which is called Achieving Person-Centered Health Systems, we try to kind of provide more background information on the concept of patient-centeredness. This concept relates to good quality healthcare, and it's considered a key element for innovating and changing our model of care, moving away from fragmented health service delivery and disease-oriented approach in healthcare, and also involving people more closely in their own care. This is really necessary because of the increased incidence of chronic conditions in all member states, which require a more active engagement of patients, also considering the fact that there are more health professionals involved, and also the growing complexity of healthcare, which risks to increase the level of inequalities, not only in terms of accessibility, but also in terms of information asymmetry and people's capability to make sure that their own needs and preferences are taken into account by health professionals. So basically, patient-centeredness relates to three aspects: voice, choice, and co-production. Voice meaning that civil society and patient organizations should be involved in shaping health policy. Choice, also giving or accepting preferences and preference of patients, and co-production, involving and engaging people collectively and individually in the delivery of their own care in a more equal partnership. This has also been put forward by WHO already since the Alma-Ata Declaration in 1978, and also confirmed 2 years ago in the Astana Declaration. In 2016, WHO adopted the global framework on integrated people-centered health services, which was also translated in a European action framework on integrated health services. And you can see in the next slide, which provides 4 dimensions where this change can be made in terms of changing the model of care. Patient rights are coming up in the first category of population and individual interventions as a way to increase the empowerment of patients and their engagement. But for that, I would like to also refer or see how patient rights are defined. And if we go to the next slide, I would like to start by saying that patient rights have been defined in very different ways, from a very narrow to a more broad approach. And I'm using here in the next slide, please, 4 main sources that also were already referred by the chair earlier on. So first of all, we have the Amsterdam Declaration of WHO in 1994, which was the first attempt to formulate a consistent set of patient rights regardless of the specific national context. In 1997, we had the Councils of Europe Oviedo Convention, which aimed to protect human dignity in the face of biological and medical advances such as genetic testing, biomedical research, etc., but also includes a set of general patient rights. And then, as already mentioned, at the EU level, in 1984, the European Parliament asked the Commission to develop a European Charter of patient rights, but it was actually a civil society organization, the Active Citizenship Network, in 2002, who brought forward a European Charter of 14 different patient rights. And based on that, we have now every year, on the 18th of April, a European Patient Rights Day that is being celebrated. And as you also mentioned, Chair, the directive on cross-border on patient rights in cross-border healthcare also includes patient rights, where this directive in the first place was meant to clarify the entitlements and reimbursement of healthcare that is provided in another member state. It also contains a set of guarantees related to quality and safety, to information, to continuity of care, which is also very much important in the context of the current pandemic, and also in relation to confidentiality and privacy. And in the next slide, based on these four sources, you can see when we look at the specific patient rights that are mentioned, there is quite some consensus on what patient rights actually are. It includes the right to be treated with respect, not to be discriminated, the right to privacy and data confidentiality, the right to informed consent and participation in clinical decision-making, the right to be informed about one's health, to choose his or her provider and to have a second opinion, the right to have access to healthcare, which is of good quality and which is also provided in a timely manner, the right to complain and to get compensation in the case of harm, and the right to be represented at each level. So in the next slide, these rights are then clustered into three main types. The first one is the classical patient rights, which are directly linked to the fundamental human right and which try to protect the patient against an unlawful intrusion. These rights are then clustered into three main types. The first one is the classical patient rights, which are directly linked to the fundamental human right and which try to protect the patient against an unlawful intrusion. These rights are then clustered into three main types. The first one is the classical patient rights, which are directly linked to the fundamental human right and which try to protect the patient against an unlawful intrusion.
the consumer protection policy. This concerns existing legislation such as the Insurance Distribution Directive, the Mortgage Credit Directive, the Consumer Credit Directive. In this regard, Article 114.3 and 169 provide the legal foundation for this intervention, as it states that consumer protection will take into account scientific facts and contribute to protecting the economic interest of consumers. 2. An alternative approach may be based on a new European legislative initiative, namely a regulation, able to ensure a common legal framework among EU countries on the right to be forgotten for cancer patients to avoid discrimination, strengthening social rights for cancer survivors. 3. Increased support for multidisciplinary research on cancer survivorship, the improvement of infrastructure and database to collect long-term data on cancer survivorship through initiatives such as the Beating Cancer Plan and the Cancer Mission. 4. Finally, I would also call for the formalization of an EU Cancer Survivorship Day, which every year could be used to raise awareness of the problem cancer survivors must overcome. Before closing my statement, I am pleased to announce that we will be organizing an online event on the right to be forgotten, 14 million to discuss.
Excuse me, you have to
Yes,
finish.
I am finishing. Yes, this meeting was originally to be take place on February 3, but due to the publication of the Beating Cancer Plan, we are currently coordinating with the Commissioner Stella Styriakides to select another date which should to be able to announce it soon. Thank you.
Bardzo dziękuję. Mam niestety niedobrą informację. Mamy kłopot techniczny. Mam zgłoszenie od techników, że mamy kłopoty z tłumaczeniem publicznym komisji i niestety muszę ogłosić 5-7 minut przerwy. Wystarczy? 2 minuty przerwy, żeby technicy poprawili kondycję naszego przekazu na zewnątrz. Bardzo Państwa przepraszam, to jest niezależne od nas. Musimy się powstrzymać na 2-3 minuty. Muszę ogłosić 5-7 minut przerwy. Wystarczy? 2 minuty przerwy, żeby technicy poprawili kondycję naszego przekazu na zewnątrz. Bardzo Państwa przepraszam, to jest niezależne od nas. Musimy się powstrzymać na 2-3 minuty. Mam informację od techników, że podobno sytuacja się poprawiła. W związku z tym wznawiamy posiedzenie. Stefan Giesels, dyrektor Digestive Cancers Europe, organizacja zarzeszająca zajmująca się chorobami nowotworowymi układu pokarmowego. Oddajmy głos, zapraszam. Wznawiamy posiedzenie. Stefan Giesels, dyrektor Digestive Cancers Europe, organizacja zarzeszająca zajmująca się chorobami
Good afternoon, can you hear me?
pokarmowego. Oddajmy głos,
Yes, we can hear you.
Great, good afternoon. Can you show the slides, please?
Zapraszam do głosu.
Yes, we can hear you.
Great, good afternoon. Can you show the slides, please? Thank you. And next slide, please. So I will talk about, in a case illustration from Digestive Cancers Europe, which is the organization that I lead. Many of the things that I will say will also be relevant for all types of cancer, but of course I know the digestive cancers best On the first slide, you can see 900,000 people in Europe get a digestive
Mr.
cancer.
Gisso, I'm really sorry to interrupt you right now, but your camera is not enabled. And to be interpreted, we need your video, your camera. Could you please enable it on the upper left of your screen?
Thank you.
Thank you very much.
Sorry. So I represent Digestive Cancers Europe. On the slide, you can see 900,000 patients get a diagnosis of digestive cancer every year in Europe, and 600,000 of them die, unfortunately. And what I will discuss here is that, in fact, most of these people should be kept alive if we apply best practices. Next slide, please. So what needs to be done? I will talk first about early detection, that point that Jan Geisler already raised, the importance of quality cancer care, and then the value of patient organizations. Next slide. Starting with early detection. So what needs to be done? Next slide, please. You can see in colorectal cancer, the 4 stages of cancer. Treatment at early stage costs €4,000 and it's €40,000 for stage 4 on average in Europe. And it can vary up to €170,000 for a late stage cancer treatment. Next slide. When you look at survival, you can see that 90% of patients survive stage 4 diagnosed in stage 1 and only 10% when they are diagnosed in stage 4. So anybody would see these figures, high survival rate and low cost, would assume that all efforts are being made to have early detection of patients and the avoidance of late stage detection. Unfortunately, and on the next slide, the reality is different. In colorectal cancer, only 13% of patients are diagnosed in stage 1, as compared to 55% in stage 3 and 4. So it's like we're waiting for patients to become extremely sick so that we can throw massive amounts of money at the system. What you can see here is the 48% early detection is achieved in the Netherlands. So few countries in Europe really have high-level performance, and I want to commend the Netherlands, Slovenia, Denmark and Lithuania for the efforts they're doing, but also some regions in Europe have very good results. And so it's not a question of east versus west or north versus south. It's a question of really political will to make sure that early detection is organized through the proper systems. I've seen that the slides are gone. So it's not a question of east versus west or north. So if every country in Europe did what the Netherlands does, that means that 130,000 patients would not die every year. And at the same time, a lot of money will be saved in the system because early detection, as you see, is relatively cheap compared to late treatment. So it would save €3 billion in medical costs and around 6 billion in total medical costs. Then we move on to the next slide. I don't see the slides anymore. Is it possible to put them up, or is it something wrong with my presentation? So it would save €3 billion in medical costs and around 6 billion.
My widzimy slajdy.
Then we move on to the next slide. I don't see the slides anymore. Is it possible to put them up, or is it something wrong with my? Yes. So in treatment, you see that % of colorectal cancer patients in Europe die. And then if you go to the next slide, in the best hospitals, 85% of patients survive. And again, this is not an east-west, north-south divide. In the same country, in Belgium, where I was treated for metastatic colorectal cancer, 85% of patients have survival in some of the best hospitals. Other hospitals have 60%, 50% survival rates. Other hospitals have not enough patients to have statistics. So if move on to the next slide. So again, if every hospital in Europe at 85% survival, 120,000 people would not die. And there's no surprise. I mean, the more patients that are in a hospital with a specific type of disease, the more the cancer centers are specialized, the more experience, the more expertise there is. The better infrastructure, the better the pathologist, the surgeon, the digestive oncologist, economies of scale, but also the more interactive systems between the patient and the treatment team, like shared decision-making models, information sessions, and things like that. Move on to the next slide. And then if you look at the entire patient pathway, and I think I will repeat what was already said, there is only one stakeholder group who really understands the full patient journey, and that is the patient. So if you go from early symptoms to survivorship, every step of the way we have experienced, and the collective experience of all the patients together can really determine how the system can be made more effective and more efficient. We have gone through it. We have the experience of every aspect of the patient pathway, and it is therefore extremely important that patients are part of the decision-making process. We know it better than anybody else. We know 100% of the treatment pathway. Next slide. And on top of understanding what needs to be done, we are also catering for the service for the patient, full patient support. So as you can see, patients who are more literate, who are better educated, who are better informed, who are less socially isolated, who are better coached and supported, have better outcomes and better quality of life. And that is what we as patient organizations do. We inform them, we educate them, we organize information sessions on sexuality, on living with stoma. We help them to find nutritional support. We help them with physical activity and rehabilitation. We organize weekends sometimes for them to make sure that they feel part of a community. So we help them in every possible aspect of the way. Patients who are part of a patient organization have better outcomes and better quality of life. Again, some of my slides have dropped away. So it's very important that the support and the value of patients' organization is recognized by health policy, because we bring significant value for patients and for society. If you then go to the next slide. Unfortunately, we are, we are funded at the moment by private donation. So it means that we live thanks to the grace of private donations, either from fundraising activities by families and friends or by industry sponsorship. It is very important for our survival, like in a year that we have encountered now with COVID, where none of these fundraising activities are possible, that we get public funding. Today, only in the Nordics and the Netherlands, patient organizations, cancer patient organizations get access to public funding, and it's very important to professionalize for us to have access to this type of funding. We cannot afford to be inefficient. Our system at the moment costs 200 billion euro every year for cancer, and 39 billion goes to digestive cancers. So if we really want to have more efficiency in the system, patient organization have to play a key role. Then I go to the last slide. So again, next slide, please. Early detection. So what we would like to see is a platform of screening agencies in Europe so that we can share best practices among all the different member states. Also that we have an oncology dashboard with early detection as one of the key parameters to measure so that we can track progress in every country. With regard to quality cancer care, that patients are only treated in hospitals who conform with the essential requirements of quality cancer care that the European Cancer Organization set up, so that the best performing hospitals also get the opportunity to specialize even more, and that hospitals with less good performance either stop doing what they're doing or improve their services. So what we want is for every hospital in Europe to be transparent about mortality figures 1 month after surgery and survival 1 year and 5 years after treatment, so that we can, as patients, can identify where patients have the best outcomes. And then last but not least is the understanding the value of patient organization. Not one single meeting on policy by the European Commission or the European Parliament should be set up without having patients as part of the discussion. We know best. Trust me, we know best. We know what patients go through. We know how the patient journey should be organized. And secondly, we have to be appreciated for the total patient support that we give. Many patients fall between the cracks. I mean, nutrition, to give one example, majority of gastric cancer patients are malnourished. And it is very cheap to resolve, and it is very easy to solve, but nobody does it. 50% of patients with gastric cancer are malnourished. Same thing with esophageal cancer. In our times, this is not acceptable. And it's not a question of money, it's a question of medical practice. So please, for patient's sake and for society's sake, make sure that patient organizations get funded in relation to the value that they generate for individual patients, their carers, and society. Thank you. For patient's sake and for society's sake, make sure that patient organizations get funded.
Bardzo dziękuję. Oddaję głos dr Stanimir Hazardziew, przewodniczący bułgarskiej Narodowej Organizacji Pacjentów, sekretarz generalny Partnerstwa na rzecz Pacjenta. Oddaję głos. Bardzo dziękuję. Oddaję głos dr Stanimir Hazardziew, przewodniczący bułgarskiej Narodowej Organizacji Pacjentów, sekretarz generalny Partnerstwa na rzecz Pacjenta. Oddaję głos.
Monsieur Hazardziew, okay, could you press the speak button once? Thank you.
Mr. Hazardziev, your microphone is enabled. Yes.
Hello? Yes. Hello, it's a real honor for me to be invited here today, and I will try to wrap up everything that the previous speaker said and put some really important points from the point of view and my position as head of the Bulgarian Patients Umbrella Organization, which is the biggest one here, but also wearing my hat being Secretary General of the Patient Access Partnership in Europe. We highly appreciate and welcome the efforts of the European Parliament and the Commission to start talking and to prepare a cancer plan that would affect millions of lives of patients around Europe. Next slide, please. We also would like to stress out that our society has achieved quite a lot and has committed already to several crucial documents which are really important and could be stepping stone for the development of healthcare systems from now on. Namely, these are the Sustainable Development Goals, where member states have committed by 2030 to achieve several very important topics and issues in our society, but mainly in healthcare, that the member states have committed to achieve sustainable healthcare systems and the rights to timely, accessible and affordable preventive and curative healthcare of good quality should be assured also through the European Pillar of Social Rights. These two documents, the Sustainable Development Goals and also the European Pillars of Social Rights, could play a key role and could be really drivers in our societies, so we can assure that the Beating Cancer Plan could be really a good example how systems could be reformed and changed in all other disease areas as well. Even the commitment of member states, we see the data that clearly show that there are huge disparities when we come on the ground and when we start talking about concrete cases and patients. These huge disparities are very visible when we talk about mortality, for example, in cancer. So the big question is, how can we make sure that the Beating Cancer Plan could actually address some of these challenges and could show to member states the way that we can overcome and collaboratively resolve many of the issues that we currently have in different countries. How we can assure universal coverage, how we can assure equity of access for all European citizens. Next slide, please. So what should be the cancer plan and how we can use the cancer plan so we can make sure that it's usable and implementable into different member states. Next slide. First, the European citizens really deserve this cancer plan and this cancer plan should be promoting excellence and provide guidance for implementation. Because as previous speakers said, many of the issues do not need more money. It's just a matter of proper organization and proper structuring the available resources so we can make sure that guidelines and guidance are equally aligned between different member states. And regardless where you live or where you have been born, you will have the same quality of access, the same procedures, the same treatments would be available for patients and European citizens when they need the help from their healthcare systems. Can really the cancer plan patients and European citizens when they need the help from their healthcare systems? Can really the cancer plan patients and European citizens when they need the help from their healthcare systems? Can really the cancer plan and to overcome many of the challenges that we currently see and have. The cancer plan needs to be a stepping stone for eradicating differences between member states, but also to provide guidance on how we provide care, how we improve the outcomes, and how we facilitate the systems so they can function in a better way, serving the needs of the patients. With this in mind, the inequalities still remain a major issue around Europe. And for example, in the COVID situation, we saw clearly how where is the link between the income level, for example, of different citizens and their access to healthcare. And this data is constantly coming out and showing us that without tackling the inequalities, without supporting member states in their efforts to assure quality healthcare, it's not possible to have our systems prepared to meet the challenges, especially in a global pandemic context. Of course, when we talk about prevention, screening, and when we're talking about digital infrastructure and high-performance computing, etc., we should not forget that European citizens living around Europe have challenges, and many of the member states need to address these challenges properly before we can talk about united European approach towards cancer and beating cancer. Next slide, please. We need to assure through the cancer plan that all European citizens would have timely access to quality healthcare. So besides being capable and being a good opportunity, the cancer plan, to provide guidance on what is quality and how we make our systems to really benchmark each other and to assure that the same quality of services is provided to all European citizens. Still, member states have huge challenges when we talk about availability of products and accessibility and affordability of those products. Therefore, I think that in the future, the cancer plan could be the basis of a further debate on the pricing model that we have in Europe. The pricing model should assure that we have, of course, transparency, solidarity, but also it could be changed in a way that it will facilitate the early and timely access. We can see huge differences in access and delays between 100 and 850 days of innovative medicines that are approved by the Medicines Agency, without assuring that all European citizens would have timely and equal access to innovation, to treatments, even to essential treatments and generics. That is not a matter of price anymore, is still a challenge in many of the member states. So how can we change the model in a way that medicines are going to be provided in a more fair way? Is Europe ready to talk about the right of patients to have access to innovation, at the same time also to tackle some of the challenges that we have with the reference pricing system, for example? Next slide, which is one of my last slides.
Excuse me.
I'm finishing.
You have to finish.
Exactly, this is my slide. This one, actually the last slide. I would like to say that the cancer plan should be, while being highly appreciated by the community as a good example, it should be really the starting point of developing such plans in all other disease areas. We cannot wait 5,000 different parliaments to come and to prioritize different diseases. But the cancer plan could be really the example that we can step on and further develop a variety of such collaborative initiatives to tackle health inequalities and to improve healthcare of European citizens. My last slide, which I would like to finish with, a statement coming from the Patient Access Partnership and the different stakeholders involved in that, in our conference for the future of health before the COVID, which is actually calling for more collaborative European efforts and cross-border multi-stakeholder cooperation in tackling health in Europe ahead. Thank you.
Bardzo dziękuję, bardzo proszę wszystkich o przestrzeganie czasu, bo inaczej po prostu mówcy się nie zmieszczą. Bardzo o to proszę zarówno naszych gości, jak i polityków o przestrzeganie czasu. Cindy Fransen, EPP, zapraszam do głosu do 3 minut. Podkreślam czas.
Okay, thank you. Thank you very much, Chair, for giving me the floor, and also many thanks to our experts. I think you all made very valuable contributions to our work, and I would like to focus on the right to be forgotten. Such a right is, of course, important for all patients, but certainly for the AYAs, the adolescents and young adults who are only at the starting point of their life. As you already mentioned, in my own country, Belgium, we have legally foreseen the interdiction for insurance companies to take into account previous cancer pathologies after 10 years from the end of the successful treatments and the absence of relapse within the same period. For some cancers, this period is shorter. For example, 1 year in case of breast cancer or cervical cancer. And there remain some national differences within these countries that already have a right to be forgotten. We do indeed need to have EU common standards, but the existing differences are something we need to take into account when harmonizing such rules in the EU. So my concrete questions are, given the differences between those member states who have already implemented the right to be forgotten, do you have more specific, more detailed suggestions regarding the conditions and the periods of the right to be forgotten? In other words, among the different national forms, which one is the common standard we need at EU level? And my second question, conditions other than those linked to financial services are urgently needed to fully guarantee cancer survivors the right to have a normal life after a successful treatment? So those are my two questions. Thank you.
Bardzo dziękuję. Alessandra Moretti, SND. Włochy, zapraszam.
Grazie Presidente e rivolgo buon anno a lei e a tutti i colleghi e spero anch'io che sia un anno di salute per tutti. Grazie agli esperti di cui ho apprezzato molto gli interventi, grandi contributi molto importanti e interessanti. Mi sembra ovvio ribadire innanzitutto che il primo diritto del paziente sia quello alla cura, che sia una cura gratuita, pubblica, universale, di qualità e tempestiva soprattutto per tutti. Il primo problema oggi in Europa è che purtroppo ci sono dei cittadini di serie A e di cittadini di serie B, a seconda del luogo di nascita o di residenza. E la speranza di vita è profondamente diversa e queste discriminazioni si possono verificare tra cittadini di paesi diversi, ma tante volte anche all'interno dello stesso paese con regioni più ricche e altre meno avanzate. Per questo motivo l'Unione Europea deve prendere l'iniziativa e ribadisco anche in questa sede la proposta del gruppo socialista di creare una Unione Europea della salute che comprenda misure legislative valide su tutto il territorio europeo per fissare tra le altre cose anche degli standard minimi di prestazioni sanitarie e diritti per tutti i cittadini europei indipendentemente dal paese di residenza. È una battaglia di civiltà. Serve poi superare l'approccio settoriale, per esempio quello della direttiva 24 del 2011 sui diritti dei pazienti nell'assistenza sanitaria transfrontaliera, che pur contenendo misure apprezzabili non è più sufficiente per raggiungere una copertura complessiva che parta dai diritti dei pazienti cittadini. A fianco al diritto primario alla salute, come abbiamo potuto sentire anche oggi dagli esperti, esistono anche diritti meno evidenti, ma non per questo meno importanti. Il cancro può essere una malattia devastante non solo dal punto di vista della salute, ma anche dal punto di vista sociale, del lavoro e quindi anche economico. Deve essere garantito il diritto al mantenimento del posto di lavoro anche durante le cure, con accorgimenti specifici se le condizioni di salute lo consentono. Deve essere consentito il diritto alla privacy, alla tutela della riservatezza e dei dati sensibili e deve essere garantito il diritto al reinserimento dopo le cure nel mondo del lavoro e in società. Vediamo e mi rendo conto che sono tutti temi complessi e mi auguro potranno essere affrontati tutti insieme nel nostro report e poi tradotti in misure legislative, non soltanto declaratorie, con la massima urgenza. Grazie.
Nicolau Stefaniuta, zapraszam.
Thank you. I listened to Dr. Geisler and to Mrs. Meunier with great attention, and I agree is already enormous. Treatment is significant and costly, as we saw in the graphs presented to us, but your disease is not the only thing in life. You continue to be a human being. You continue to be a citizen, a consumer, a mortgage taker, a person. So what do you do when your credit is cut? What do you do if you can no longer buy insurance? What do you do if your mortgage becomes all of a sudden more expensive? These are all very legitimate questions, in addition to the right to be forgotten, because Europe is a place that is famous for ensuring that its citizens have equal rights in relation with the banks, with financial institutions, and others. We are the place in the world with most transparent and clear rights for consumers. That's why I urge Stella Kyriakides to take account of these various aspects in her strategy that will be released on the 3rd of February. And I would like the speaker to mention again which points of legislation, I know Mrs. Meunier listed a couple of items, what points in our current legislation she should like to see reversed in order that our patients do not get unequal treatment. I conclude by saying this is not only the case in relation to cancer patients. It is also for organ donors, for instance. Organ donors who, after having committed a heroic gesture for society, they then go on and have higher mortgage payments, higher insurance costs, because the financial institutions don't trust their future, basically. How do we treat these people and tell them they are exactly equal to us and they are human and normal and valuable citizens to society? Thank you.
Thank you. Jean-Benoît, ID, zapraszam.
Equal to us and they are human and normal and valuable citizens to society. Thank you.
Thank you. Jean-Benoît, ID, zapraszam.
Oui, merci Monsieur le Président, merci à tous les experts. J'ai assez naturellement une grande réticence à l'égard de l'expression de droits unilatéraux ou du terme de stigmatisation. Je suis persuadée que la dignité humaine passe toujours par la responsabilité individuelle. Cela dit, l'annonce de la maladie, puis les démarches diagnostiques, thérapeutiques ou de réadaptation, que ce soit dans la vie personnelle, familiale ou professionnelle, restent toujours des moments d'un réel chemin de croix pour les patients. Le patient et ses aidants sont donc à des degrés divers pris entre deux démarches, celle d'une aide extérieure et celle de la reprise en main de sa vie personnelle. Les aides peuvent bien sûr venir des soignants, que ce soit dans la prise en charge sur les effets secondaires des traitements, les médicaments ou la chirurgie, la réadaptation au moment des douleurs ou bien de l'impact moral. Les aides peuvent venir de la famille qui, elle, doit être guidée au maximum dans la clarté et l'efficacité. Mais aussi, l'aide peut venir de l'environnement professionnel. Mais à ce propos, il est clair que les employeurs ne peuvent pas tout et qu'il est de l'ordre des obligations régaliennes d'un État que de mettre en place un système qui évite les excès à l'égard des personnes temporairement ou définitivement fragilisées. Je pense en particulier aux assureurs et aux banques qui peuvent bien souvent paraître très sévères à propos d'aléas de la vie. Le droit à l'oubli, en l'occurrence, est fondamental. La question qui se pose actuellement est la suivante. L'impact du Covid se fait sentir dramatiquement à toutes les étapes. De la maladie, retard au diagnostic, aux soins et déséquilibre dans les systèmes et les lieux de soins. Mais il convient aussi d'envisager les conséquences à plus long terme, au plan de la résilience des systèmes sociaux, en particulier sur le versant chômage et retraite. Ma question est à M. Hazardiev. Les associations de patients ont-elles commencé à faire des projections sur l'aggravation des moyens financiers des différents systèmes nationaux de protection sociale afin que le plan cancer envisagé soit le plus anticipateur possible, à la fois au niveau européen éventuellement, mais surtout à mes yeux dans chaque État membre et lors des démarches de coopération entre États. Je vous remercie.
Dziękuję bardzo. Michel Rivasi, Zieloni, zapraszam.
Voilà. Merci Monsieur le Président et bonjour à toutes et à tous et bonne année et bonne santé avec une santé durable. Merci pour toutes les interventions. Alors, moi j'avais des questions à poser pour savoir quelle est la meilleure stratégie. D'abord, les associations de patients, c'est très important pour les législateurs que nous sommes parce que vous pouvez pousser dans chacun des pays le principe d'égalité, d'accès aux soins, de bonnes pratiques, etc. Alors, je voudrais, pour moi, la première partie qui incombe beaucoup au niveau de l'Europe, c'est l'égal accès aux soins. Et ça joue aussi sur le prix des médicaments, parce que quand on regarde sur le cancer, les médicaments concernant le cancer deviennent de plus en plus chers. Alors, je voulais savoir quelle était la pratique des associations de patients. Est-ce que vous demandez, par exemple, la transparence des prix? Est-ce que vous demandez quelle est la part que l'argent public met dans la recherche et développement, vous voyez, pour qu'on ait des prix acceptables et non pas que ce soit les labos qui fixent les prix. Il y a une autre partie qui a mal été abordée, c'est le problème de la médecine intégrative. Parce que lorsqu'on a un cancer, alors c'est sûr qu'on a des traitements, que ce soit de chimio, que ce soit de chirurgie, que ce soit d'autres, mais il y a de plus en plus des expériences, notamment en Allemagne, qui montrent qu'il peut y avoir plusieurs médecines qui aide le patient à mieux supporter certains types de thérapies. Donc je trouve que là-dessus, il faut encourager cette médecine intégrative. Troisième chose sur les meilleures pratiques. Vous en avez parlé. Moi, je pense que là-dessus, il faut une incitation de l'Europe pour qu'il y ait un échange sur les meilleures pratiques. Et dernière chose qu'a abordé Françoise Meunier, c'est le droit des patients. Est-ce qu'il ne serait pas intéressant d'avoir une directive européenne qui renforce le droit des patients, que ça soit sur l'information, que ça soit sur les assurances, que ça soit sur la possibilité d'emprunter, parce que là-dessus, il y a une différence énorme entre les États, et ça pourrait être une valeur ajoutée qu'apporte l'Europe par rapport à une directive européenne. Les assurances, que ça soit sur la possibilité d'emprunter.
Bardzo dziękuję. Joanna Kopcińska, EKR, zapraszam.
Valeur ajoutée qu'apporte l'Europe par rapport à une directive européenne. Les assurances, que ça soit sur la possibilité d'emprunter.
Bardzo dziękuję. Joanna Kopcińska, EKR, zapraszam.
Valeur ajoutée qu'apporte l'Europe par rapport à une directive européenne.
Bardzo dziękuję. Joanna Kopcińska, zapraszam. Nie mamy połączenia, w związku z tym Katarzyna Koneczna, GUE, Czechy, zapraszam.
Děkuji, pane předsedo, vážené kolegyně, vážení kolegové. Já jsem chtěla poprosit o odpověď na 3 otázky.
Przepraszam bardzo. Jakość połączenia uniemożliwia tłumaczenie.
Okay.
Katarina, popraw internet.
Okay. I try to reconnect. I think it's only one way out to find solution.
To może spróbujemy za chwilę, Katarina. Przejdziemy dalej i wrócimy do Ciebie. Zgoda?
Okay.
Ja też mam jakiś pogłos podwójny w swoich słuchawkach. Też jest jakiś błąd techniczny, zwracam uwagę. Dolores Monserrat, IPP, zapraszam. Do 2 minut. Też mam jakiś pogłos podwójny w swoich słuchawkach. Też jest jakiś błąd techniczny, zwracam uwagę. Dolores Monserrat, IPP, zapraszam. Do 2 minut.
Now. Muy buenas tardes y muchas gracias a todos los expertos que han intervenido hoy. Quiero poner la atención no solo en el derecho al olvido, sino también sobre el impacto socioeconómico y laboral del cáncer, que afecta a la calidad de vida de los pacientes y sus familias. Las dificultades socioeconómicas y laborales pueden ser devastadoras. Gastos para medicinas de soporte, dietas especiales, fisioterapia, rehabilitación, psicoterapia, costes de viajes, alojamiento, aparcamientos, manutención, por vivir lejos, a muchos kilómetros de los hospitales, y tantos otros imprevistos que aumentan los gastos mensuales por familia entre 150 y 500 euros mensuales. Y aquí debemos añadir el impacto laboral, como la imposibilidad de realizar trabajos con sobreesfuerzo físico o mental, o cuando te declaran una incapacidad temporal o permanente, muchas veces la pensión es insuficiente, y en otros casos la imposibilidad de reinsertarse laboralmente, así como también la pérdida de cotizaciones, que esto afecta a las pensiones de jubilación, o el derecho al olvido, que hoy se ha hablado y mucho. Pero quiero poner el foco en los colectivos de personas en situación económica de riesgo que se ven aún más agravados por el diagnóstico cáncer, que mayoritariamente son los autónomos. Ese autónomo que cada mañana levanta su persiana de su comercio, seguidas de las personas en situación de desempleo y, por último, las personas con bajos ingresos. Por tanto, las personas con cáncer se enfrentan a 3 dimensiones que ven amenazadas. Primero, el bienestar físico y mental, y el social, que significa el económico y también el laboral. Dicha enfermedad impacta y tiene repercusiones en todas las esferas de la vida de la persona enferma y su familia. El diagnóstico de cáncer se convierte en un momento de crisis vital para la persona y su entorno, pero también para toda la sociedad. Y por todo ello debemos implicar una importante transformación a todos los niveles administrativos y de la sociedad. Tenemos mucha información sobre la incidencia del cáncer en la salud, pero pocos estudios sobre el impacto en la economía y la vida laboral de los pacientes. Necesitamos, por tanto, garantizar a todos los pacientes de cáncer en Europa una protección social y laboral adecuada. Por ello, le quiero preguntar al director Ryan qué medidas sobre este tema están previstas en el Plan Europeo para vencer el cáncer. Creemos muy importante encargar a la Agencia Europea para la Seguridad y la Salud en el Trabajo de monitorear y difundir las mejores prácticas de protección social y apoyo laboral y derecho del olvido. Muchas gracias.
Musimy kończyć.
Creemos muy importante encargar a la Agencia Europea para la Seguridad y la Salud en el Trabajo de...
Proszę bardzo, wróciła łączność z panią poseł Kopcińską. Zapraszam do głosu. Musimy kończyć. Proszę bardzo, wróciła łączność z panią poseł Kopcińską. Zapraszam do głosu.
Okay, I hope that everything will be better than before. If you hear me, and yes, great. Já budu mluvit česky. Já bych se chtěla zeptat na 3 věci. O jedno téma se tady zajímali i všichni mý kolegové a myslím, že bude velmi důležité, abychom doporučení ve zprávě k němu dali zcela konkrétní, a to je to právo být zapomenut. Jestli jsem správně paní Manier pochopila, tak taková, respektive by se dala využít už směrnice, která existuje, dala by se využít zakládající smlouva Evropské unie, takže pokud by nám k tomu mohla třeba poslat více podkladů, abychom mohli dát konkrétní návrh komisi, jakým způsobem má postupovat a celoevropsky to sjednotit. Určitě by to bylo velmi přínosné pro pacienty, pro společnost, pro všechny. Druhý můj dotaz, ten mám na pana Geisla, který tady mluvil o tom, že ten výzkum ve východní Evropě není takový, jaký by měl být, zvlášť u rare diseases. Mě to dost překvapilo, protože my máme spoustu expertů, já jsem z východní Evropy a máme řadu expertů, máme řadu klinických pracovišť, a kde on vidí ten zásadní problém, proč ten výzkum není takový, jaký by mohl být, a ty data potom z něho nemůžou být takto využívána. A třetí můj dotaz směřuje k panu Giesel Štefanovi, který moc hezky mluvil o tom, jak brzké zjištění a prevence může znamenat nejenom 120 000 méně mrtvých lidí, ale také finanční snížení nákladů. A opět mluvil o některých státech a chtěla bych se ho zeptat, jestli vidí nějakou cestu celoevropskou, anebo je opravdu jenom na těch členských státech, jak si například ty screeningy a tu diagnostiku včasnou v podstatě dají dohromady, nebo jestli vidí nějaký náš potenciál, jak bychom mohli pomoct tomu, aby všichni pacienti mohli být, nebo všichni občané mohli být včasně diagnostikováni v celé Evropě. Děkuji. Nebo jestli vidí nějaký náš potenciál, jak bychom mohli pomoct tomu.
Bardzo dziękuję. Nie wiem, czy jest z nami poseł Kopcińska. Fizycznie na sali, czy
Dziękuję
online?
Panie Przewodniczący.
Nie, online.
Dziękuję.
Witam.
Dziękuję. Dzień dobry, dziękuję Panie Przewodniczący, dziękuję wszystkim zaproszonym gościom. Z zainteresowaniem wysłuchałam Państwa wystąpień. Wiele organizacji słusznie deklaruje, że podstawowy element każdego programu prac poprawy opieki zdrowotnej pacjenta musi uwzględniać perspektywę, w której unikalna wiedza i doświadczenie przechodzą w kierunku ukierunkowanej na pacjenta profilaktyki, diagnostyki, leczenia i opieki. Od wielu lat organizacje te oferują pomoc ekspercką oraz wsparcie edukacyjne w dziedzinie m.in. chorób nowotworowych, starając się realnie uwzględniać tak zwaną perspektywę nazywaną uczestnikiem z wewnątrz. W kontekście perspektywy uczestnika z wewnątrz chciałam zapytać, jakimi doświadczeniami mogliby się Państwo podzielić, zwłaszcza w kontekście Europejskiej Sieci Referencyjnej Genturis Huracan, ale mam tu na myśli szczególnie jedną sieć referencyjną, która specjalnie dedykowana jest nowotworom u dzieci i młodzieży, a mianowicie PETCAN. Chciałam zapytać, w jakim stopniu udaje się wykorzystać tę perspektywę uczestnika z wewnątrz w kontekście tak trudnego tematu, jakim jest onkologia dziecięca. W jaki modelowy sposób proponują Państwo wcielać Europejski Kodeks Postępowania Onkologicznego, a zwłaszcza punkt 10 kodeksu mówiący o pełnej reintegracji pacjenta, w tym przypadku mówimy o dzieciach, w sposób praktyczny, aby umożliwić im powrót nie tylko do społeczeństwa w przyszłości, ale i na ile to jest możliwe odbudowanie utraconego dzieciństwa. W jaki sposób w Państwa opinii wiedza z doświadczenia działania tych organizacji powinna kształtować przyszłe decyzje polityczne faworyzujące uwzględnienie perspektywy uczestnika z wewnątrz oraz jakie dotychczasowe działania stanowią matrycę dla kolejnych przyszłych działań, zwłaszcza w ostatnim ogniwie sieci referencyjnych do spraw raka, odnosząc się do pełnej reintegracji po przebytej chorobie nowotworowej. Kolejnych przyszłych działań, zwłaszcza w ostatnim ogniwie sieci referencyjnych do spraw raka, odnosząc się do pełnej reintegracji po przebytej chorobie nowotworowej. Kolejnych przyszłych działań, zwłaszcza w ostatnim ogniwie sieci referencyjnych